Hello everyone, welcome to ENT Mastery course. I am Dr. Mehak and in this presentation we are going to talk about temporomandibular joint anatomy. Now this is a very important topic for you guys, not just the anatomy part but also the examination of temporomandibular joint is very important for your practicals. And even when you're seeing patients in OPD, a lot of patients come with temporomandibular joint disorder. So examination of TMJ is very important. So but that I'm going to discuss in clinicals later on. So let's just talk about TMJ anatomy. This is also important. Unless you understand the anatomy, there is no point of reading about disorders and the other aspect of TMJ. So I'll be covering this topic under following headings. First we'll talk about development of TMJ, then introduction, then we'll talk about each part of TMJ: mandibular fossa, joint capsule, mandibular ligaments, then articular disc, then relations of TMJ, blood supply, nerve supply. Now these part are not very important, like the relationship of TMJ, blood supply, nerve supply, they are not very important. Then venous drainage is not important. Now movements of this joint is very important that you should know. uh, let's start this topic. So first let's start with the development. So the TMJ derives from first pharyngeal arch, and the development of TMJ is divided into three stages: blastemic stage, cavitation stage, and maturation stage. So in blastemic stage, there is basically formation of the glenoid fossa, the upper part of the TMJ. Okay, so that occurs at the 7 to 8 week of gestation, where there is formation of glenoid fossa and the condylar blastema occurs. Then there is a cavitation stage where there is a formation of lower joint space begins, that differentiates into multiple layers to form lower synovial layer and what will become the joint disc. Okay, so there is something called as intra-articular disc. So that is formed by this cavitation stage, and this happens between 9 to 10th weeks of gestation. Now in maturation stage, the upper joint space begins to form towards the 11th week of gestation. Around 17 weeks, the joint capsule forms. So the joint capsule is also called as fibrous capsule, while that is one of the ligaments of TMJ. While in 19 to 20 weeks of development, the cartilage inside the capsule can be recognized. Now now the morphology of glenoid fossa and condyles will be under the influence of mechanical forces and the vessels of the neighboring muscles. Now between 5 to 10 years of age, the condyles grow in their posterior, lateral and upward direction. The joint space will further be managed by mechanical forces of teeth and chewing muscles. So the development of TMJ is not very important. Even if you want to skip that part, you can. Now coming to the main anatomy of TMJ. So it is a gingilomo-arthroidal articulation. So gingilomoid basically means hinging movements in the upper compartment, and which occurs in the upper compartment. So upper compartment, so what happens is there is this articular disc in the TMJ that divides the TM joint into upper and lower compartment. Now upper compartment is basically responsible for hinging movement, that's why it is called as gingilomoid joint. And the second one is the arthrodial joint, that is because it provides gliding movements in the lower compartment. Now the movements that are occurring are gliding and hinge movements, and it is also called as compound joint. Now what is compound joint? For you to call it a compound joint, there should be at least three we require three bones that are articulating. Okay, but here there are only two bones. But why are we calling it compound joints? Because the articular disc, which is also which is not a bone basically, but it is considered as a non-ossified bone. So that's why we are considering that there are three bones here. Okay, now so the osseous portion of joint are anterior portion of mandibular glenoid fossa. So let's see that in this picture. So the bones which are responsible for forming TM joint are, so the anterior portion of the mandibular or glenoid fossa, so this is the glenoid fossa. Then we have articular eminence, so this is the articular eminence. So the prominence from the posterior bone of the zygoma is called as articular eminence. And there is this condyloid process of the mandible. So these are the osseous bone. So the osseous portion of the joint are the anterior portion of the mandibular or the glenoid fossa, the articular eminence of the temporal bone, and the condyloid process of the mandible. Basically, articular eminence is a part of zygomatic bone, not the temporal bone. So articular eminence forms the medial bone prominence at the posterior border of the zygomatic bone. Okay, so now so this is the picture which we just saw. Now yeah, it is, so now interposed between condyle and temporal bone is the articular disc, and it consists of dense collagenous connective tissue that is there in the central area and is relatively avascular, hyalinized, and devoid of nerves. So this is your TM joint. Okay, this is a very important diagram. This is your head of the mandible and condyle, and then this is the mandibular fossa. This is the articular tubercle or articular eminence, you can say. This is the fibrous capsule, which is the joint capsule, which is also called as joint capsule. So this these dotted lines, so this is basically surrounding the entire TM joint, so that's why it is like this. And yeah, so these are the parts, and this is the intra-articular disc which divides it into upper joint space and the lower joint space. So like I told you, in upper joint space, hinging movement takes place. Okay, so and in the lower, gliding movement takes place. So now talking about mandibular or the glenoid fossa. So it's an oval or oblong depression in the temporal bone just anterior to the auditory canal. Now it is bounded anteriorly by articular eminence, externally by the middle root of zygoma and the auditory process, and posteriorly by the tympanic plate of petrous portion of this bone. Okay, so now the shape of the mandibular fossa conforms to some extent, although not exactly, to the posterior and superior surface of condyloid process of the mandible. Now talking about the joint capsule, now this joint capsule is also called as fibrous capsule. Now TMJ is enclosed in a capsule that is attached at the borders of articulating surface of the mandibular fossa. So superiorly it is attached to the mandibular fossa like this, we can see, and the eminence. So it is attached to the articulating surface of the mandibular fossa and the eminence of the temporal bone, and inferiorly it is attached to the neck of the mandible. Now anterolaterally the side of the capsule may be thickened to form a band that is referred as temporomandibular ligament. So this is another ligament. So anterolaterally this ligament, this capsule itself can thicken and it forms a lateral ligament or temporomandibular ligament. So temporomandibular ligament is also called as lateral ligament. Now the anterolateral side of the okay, so the capsule consists of internal synovial layer and the outer fibrous layer containing veins, nerves, and the collagen fiber. So in this picture also we saw this is the fibrous capsule and this surrounds the TM joint. Now the innervation of the capsule arises from trigeminal nerve and several types of receptors. The vascular supply arises from maxillary artery, temporal, and mesenteric arteries. Now talking about the mandibular ligaments, so we have two types of ligaments. First let's talk about accessory ligaments, and then we have functional ligaments also. Now if we talk about accessory ligaments, in that we have stylomandibular and sphenomandibular ligaments mainly. These, now why do we call them accessory ligaments? Because these ligaments do not have direct relationship with the mandibular articulation, although they may stabilize articular system during the jaw movement. Now this sphenomandibular ligament, so if we talk about sphenomandibular ligament, so they arises from the angular spine of the sphenoid bone and from the petrotympanic fissure and ends in the lingula of the mandible. Now through the petrotympanic fissure, it may extend superiorly and it involves the malleus and forms some fibers of anterior ligament of malleus. Now in some books, this particular ligament that extends from petrotympanic fissure till the anterior ligament of malleus, so in some books it is given that this is the part of the sphenomandibular ligament only, and in some book they have named it as a separate ligament, that is malleomandibular ligament. We'll talk about that. Now it is a remnant of dorsal part of Meckel's cartilage. Its main task is to protect TM joint from excessive translation of condyle after 10 degrees of opening of mouth. Now these ligaments are related. Now the relationship of this ligament is not very important here. Now basically this ligament is related laterally to the lateral pterygoid, auriculotemporal nerve, maxillary artery, cauda tympani nerve and the wall of pharynx, and near its lower ends it is pierced by mylohyoid nerves and vessels. So like this in this picture you can see so the relationship, its relationship with the auriculotemporal nerve and the maxillary artery. Okay, and then here you can see, so this is a picture basically. This is a superficial relations of the sphenomandibular ligament after removal of the lateral pterygoid. And in this picture, this is a coronal section, and this is through the this coronal section is taken through the infratemporal lobe, and this is also showing the relation of sphenomandibular ligament. So this picture we will even see when we discuss about this anatomy of pterygopalatine fossa. Also in that, there also we will see this picture. So here you can see its relationship with the mylohyoid nerve. Like I told you, inferiorly it is pierced by the mylohyoid nerves and vessels, and also from the cauda tympani nerve is also related to the sphenomandibular ligament. So this is about sphenomandibular ligament. Now next is the stylomandibular ligament. Now this is, if you remember, we had discussed about stylomandibular ligament and deep cervical fascia also. So it is a thickened part of deep cervical fascia which separates the parotid and submandibular salivary gland. It is attached above to the lateral surface of the styloid process and below to the angle and the posterior border of ramus of mandible. Okay, so this is it. So this is the stylomandibular ligament here. And this is again the capsule, and this is what the lateral temporomandibular ligament is. So we'll lateral or temporomandibular ligament is, we'll talk about that. Now there is one more ligament like about which I spoke. So that is called as pinto or malleomandibular or discomalleolar ligament, that has two portions. So first concerns the middle ear, involves the malleus relative to the anterior ligament of malleus, and second involves the extratympanic area, the portion of TM joint capsule posterior superior in contact with the retrodiscal tissue. Now we will see what is retrodisc also in coming slides. Now it has two functions. Since it has two parts, it has two functions. Now first, for TMJ protects the synovial membrane with respect to the tension of the surrounding structure, and the second is with respect to the middle ear. So for the middle ear, it would seem to manage or influence adequate pressure to this for this area of the ear. Now other ligaments are functional ligaments, in that we have temporomandibular ligament or lateral ligament, collateral ligaments, and capsular ligament. Capsular ligament is same as what we discussed before, that is joint capsule. So talking about collateral ligaments, so they consist of two bundles of symmetrical fibers that originate at the level of intermediate fascia of the articular disc. So what happens is, like, this is your articular disc. So from here the collateral ligaments arises and they attach to the condyloid process. Okay, so these are your collateral ligaments here. This is your articular disc here, and this is the fibrous capsule which is surrounding the whole TMJ joint. So sometimes you can even call it, like in this cut section, you can call it as lateral capsular ligament or medial capsular ligament. This is nothing but the capsule, joint capsule. Now, so the collateral ligament consists of two bundles of symmetrical fibers that originate at the level of intermediate fascia of articular disc and insert at the medial and lateral poles of mandibular condyles. It anchors the disc to the condyle and helps in hinging movement. So it is also called as discal ligament. Now, lateral or temporomandibular ligaments has two parts. Well, first is the oblique portion and the second is the horizontal portion. Oblique portion, so this is the oblique portion here, and this is the horizontal portion. So oblique portion is attached above the articular tubercle and below to the posterior lateral aspect of the neck of the mandibular. Okay, now it resists excessive dropping of the condyle, so limiting the extent of mouth opening. Now, horizontal portion is from the outer surface of the articular tubercle of the zygomatic process posteriorly. From the outer surface of the articular tubercle to the zygomatic process posteriorly, and it limits the posterior movement of the condyle and disc. Now, talking about the articular disc, so the interarticular disc consists of fibrous tissue, that is, it is fibrocartilage shaped to accommodate the shape of the condyle and concavity of the mandibular fossa. The thicker anterior and posterior bands and a thin central, that is intermediate zone, is present. Now the disc divides the articulating surface into upper and lower compartments, which is filled with the synovial fluid and that provides nutrition and lubrication. So like I told you, there is this articular disc in between, and that divides the compartment into upper and lower compartment, and that is filled with the synovial fluid. Now the upper compartment permits mainly gliding, and the lower compartment helps in, so gliding takes place in the upper compartment, and in the lower compartment rotation or hinging takes place. Along with that, little bit of gliding movements also, but mainly rotatory or hinging movements in the lower compartment, and in the upper compartment gliding movements. I think previously I told the opposite thingy. So that's not correct. So in the upper compartment, gliding movement takes place, and in the lower compartment, rotatory or hinging movement takes place mainly. Now the disc has concavo-convex superior surface and concave inferior surface. The periphery of the disc is attached to the fibrous capsule, and the disc represents the degenerated primitive insertion of lateral pterygoid. So the lateral pterygoid muscle also attaches to the disc and to the mandibular condyle. So it is basically degenerated primitive insertion of lateral pterygoid. Now what is retrodiscal tissue? Now here in the articular disc, here this part has a vascular tissue that is called as retrodiscal tissue. Now, retrodiscal tissue or the posterior attachment are found between the disc and the posterior wall of the articular capsule. These tissues are highly vascularized, well innervated and loose connective tissues. Now, talking about capsular ligament or fibrous capsule or joint capsule, this is joint capsule. So that we have already discussed, and the more points that I would like to put here are: it resists medial, lateral and inferior forces that prevents the dislocation of the articular surface, and it encloses the joint and thus retaining the synovial fluid, and it provides proprioceptive feedback. Now, talking about relations of TMJ, so the laterally it is related to skin, fascia, parotid gland, temporal branch of facial nerve. Medially, it is related to the tympanic plate that separates the joint from internal carotid artery, spine of sphenoid with the upper end of the sphenomandibular ligament, attached to it, and the auriculotemporal and the cauda tympani nerves and middle meningeal nerves. Anteriorly, it is attached to the lateral pterygoid and the mesenteric nerves and vessels. Posteriorly, it is it is related to the parotid gland that separates the joint from EAC, superior temporal vessels, and the auriculotemporal nerve. Superiorly, we have middle cranial fossa and middle meningeal vessels, and inferiorly maxillary artery and vein. Now so that was easy. So the relations of TMJ are not very important. So talking about the blood supply of TMJ. So now talking about the blood supply. So the blood supply of TMJ is circumferential. Now the blood vessels of TMJ mainly originate from superficial temporal and maxillary artery. The other vessels are branches of external carotid artery. So in that we have posterior auricular artery, ascending pharyngeal and middle meningeal artery. Now talking about the nerve supply, so most of it is supplied by auriculotemporal nerve. Additional innervations are from deep temporal and mesenteric nerve. So like in this diagram, you can see the auricular temporal nerve leaves the mandibular nerves behind the joint and ascends laterally and superiorly, and it wraps around the posterior region of the joint. And the other two nerve supply goes to the anterior portion of the TMJ. Now, venous drainage, so it occurs through the pterygoid plexus in the retrodiscal area in communication with internal maxillary vein, the sphenopalatine vein, the middle meningeal vein, the deep temporal veins, the mesenteric veins, and the inferior alveolar veins. Now, talking about the movement, so the upper compartment is called as the meniscotemporal compartment, which is between the and the lower compartment is called as meniscomandibular compartment, which is between the disc and the head of the mandible. So the movements of the joint can be divided into those between the upper articular surface and the articular disc, that is the meniscotemporal compartment, and between the disc and the head of the mandible, that is meniscomandibular compartment. Now these movements occur simultaneously at right and left temporal temporomandibular joints. So we have these movements. First is your depression, that is open mouth, that is by the lateral pterygoid muscles, assisted mainly by the lateral pterygoid muscles, that is assisted by gravity, and all the suprahyoid muscles that fixes the hyoid, that is digastric, genohyoid, and mylohyoid muscles. Elevation is done, that is closed mouth, that is done by temporalis, mesenteric, and medial pterygoid. Protrusion is done by protraction of chin, that is done by lateral pterygoid assisted by medial pterygoid. Retrusion is done by retraction of chin. Retrusion is retraction of chin, that is done by posterior fibers of temporalis mainly. Then the deep part of masseter, genohyoid, and the digastric muscle. The lateral or side to side movement in chewing or grinding, that is, so if the chin is turned to the left side, that is, so the action so the muscles which are in action is left lateral pterygoid and the right medial pterygoid, and vice versa. Now let's see about each movement in detail. So if we talk about protraction and retraction, so this is the movement, this is protraction, this is retraction. So this is basically this basically occurs in the upper compartment, that is here only mainly gliding movement is occurring. So the articular disc plus the head of the mandible glides forwards over the upper articular surface, and the reversal action is called as retraction, and here the axis of rotation is the horizontal axis connecting the two condyles. Now talking about depression, so this is the depression movement. So the depression movement is basically opening of the mouth, okay, and that is divided into two parts, slight opening and wide opening. So opening of the mouth or depression of the mandible, the head of the mandible moves on the undersurface of the disc like hinge in the lower compartment, okay. So here hinging movement occurs and basically lower compartment is involved here. Okay, so the axis of movement is vertical axis. But when you open your mouth widely, the hinging as well as gliding movement occurs. So the hinge like movement is followed by gliding of the disc and the head of the mandible, as in protraction. At the end of this movement, the head comes to lie under the articular tubercle. This movement is reversed in closing the mouth or elevation of the mandible. So this is the more opening of the mouth, wide opening of the mouth. Then we have chewing movement. So in chewing movement, you have side to side movement and forward movement. So this is how it is, okay? There's forward as well as side to side movement. So the one joint will move forward and one will have side to side movement. So these movements, in these movements, the head of the right side glides forwards along the disc as in protraction, but the head of the left side rotates on the vertical axis. Okay, so if there is, movement on the right side, yeah, if there is movement on the right side, so the head of the right side glides forwards along with the disc as in protraction, but the head of the left side rotates in the vertical axis. As a result of this, the chin moves forwards and to the left side. That is the side on which no gliding has occurred. So that is what happens in the chewing movement. Now, along with these movements, you should remember all these muscles which are responsible for these movements. Okay, this is important. So that's all guys about this presentation. Like I told you before, this is an important topic and TMJ palpation is also very important. So yeah, whatever diagrams I have shown you here, that those are important and very easy to draw. Please learn those diagrams. And yes, the movements are also important, because whenever, even suppose if you get a, if the examiner asks you to palpate TM joint, then the next question will be, what are the movements of TM, what are you looking for? So you should be aware of these things, what muscle will cause protrusion, what will cause retrusion. So those things are important. So that's all about this presentation. Thanks a lot. Bye bye.